Dear class, good to see you guys again, at least electronically. I want to follow up on our next lecture on Bioethics II, Law Enforcement and Medical Scarcity, which is a great companion to the previous class on empathy and rationing. The first lecture was the vital, critical role of empathy in caregiving, and also how you have to reconcile empathy with those situations where you have to ration. And the readings the last class were rationing of ventilators. How do you do that in terms of justice and ethics? This class takes the issues of empathy and compassion and rationing and applies it to the issues of addiction and limits on surgeries for things like endocarditis and limits on things like Narcan and naloxone and the issues that those raise, those incredibly powerful and life-saving medical innovations. And how do you manage the scarcity of those? And then what happens if they in some way, shape, or form impact the very thing that they were made for in the first place, which is saving people? What if in some way having more Narcan and naloxone available makes some people who are struggling with addiction a little less careful because they know more of this is in the region? And that we're continuing this challenge of how do empathy and compassion play out in the healthcare field, and how much empathy and compassion can you have, do you need to have, and then what happens if you can't replenish it? What happens if, and you saw this in the documentary about in heroin, you saw people like Jan Rader who seem like they have they have endless amounts of empathy and compassion, and they'll save you 50 times and more. But you also saw firemen who were like, gosh, I'm getting a bad attitude and I don't have unlimited amounts. And that's a reality too in the healthcare field. And then how do you deal with rationing? This is another great case study in rationing. And the first article you all read was by Christopher Caldwell called American Carnage, which is about the opioid scourge that has been ravaging our country, first at the pills, and then when pills got clamped down on, and heroin, which became cheaper and just as, if not just as available, even more available. And as you know, the origin is that, in our profit-oriented culture, we took a drug that we had discovered 100 years ago, morphine, out of opium, which is a phenomenal drug for horrific end-of-life and cancer pain. Thank goodness we have it for that kind of stuff. Really extraordinary, crushing pain. And then we learned our lesson at different points in history that these drugs are wildly addictive, destructively addictive, and we clamped down on their use. But lo and behold, there's money to be made, and drug companies came back in the 1990s and said, "Hey, we're under treating pain," which we probably were, and we still struggle at times under treating pain. Sometimes based on race. There's studies to show that sometimes African Americans aren't believed as much when they report pain as white people are. So we probably are under treating pain. We come back with a new version of opium and morphine in the form of oxycodone or Oxycontin. And the drug companies say, "Hey doctors, it's a fifth vital sign. And you need to ask people about pain. It's very subjective." And sure enough, they just created so many of these pills because the marginal cost is so low, and they flooded markets with them. And it was, the proper use of these drugs is life-saving and wonderful. But when they fall out of proper use and they're just in people's homes, well, people are going to find them and stumble onto them and become addicted. And then you got an addiction problem. And then the obvious thing then is, we'll clamp down on the pills, which we did. We clamped down on the distribution of these pills, and then the addicts, if they don't get treatment, are still addicts, and they will go out and other vendors will provide basically the same chemical ingredient in heroin. And I just think there's elements of this article, American Carnage, that are really interesting. Having read a lot of your SAC papers, I think I agree with you that sometimes at the end of this article, you're like, well, what does Christopher Caldwell think we should do? He doesn't want us to become too politically correct and about addiction. Like, addiction's bad, it's horrible, let's keep calling it that. But on the other hand, then what are we going to do? Like, what's the proper approach? And I actually think his article, in not really coming out with a clear cut what to do, is actually pretty honest, because this problem is intractable. If it was easy, if we just switched to treating it like a public health problem, boom, it'd be over. Well, it isn't that easy. And he just, the article is to try to help us understand what it's like to have an addiction, because if you don't have an addiction, reading these articles and trying to understand why people do this is so impossible. And so this main reason of this article is to say, addiction actually has a rationality to it. Addicts resist known cures even to the point of death. If you do not reckon with why addicts go to such lengths to continue suffering, you're unlikely to figure out how to treat them. And his argument is that, addicts have a logic, that actually the addiction gives them the logic. It gives them a purpose that maybe before that they didn't have. And people want a purpose. And if they don't have one, an addiction can become one, which is the purpose is to get high again. And if you understand that at a basic level, then addiction begins to be a bit more understandable. And he profiles that some of the best groups, this guy is they're peer-to-peer. And this goes back to the 2 articles in the first class about sometimes the best doctor for a patient is a doctor who's had the same condition as that patient. And these recovery groups leverage the peer-to-peer former addict to current addict power of saying, I know what you are going through. I've been there. And the empathy that comes from that bond. And if you're in a support group and you're an addict and other people aren't addicts, then maybe you don't open up. Maybe you don't get the help you need. But if you're looking around at people who are just like you and have gone through what you've gone through, and they can show you a path out, then these programs can leverage the power of compassion and empathy. This is another great example about the power of empathy. You can leverage it for those who can't be reached by other people. And Christopher Caldwell goes on to say, the founders of Alcoholics Anonymous thought there was something satanic about addiction. The mightiest sentence in the book is, remember that we deal with alcohol, cunning, baffling, powerful. The addict is, in his own life-damaged way, rational. He's too rational. He is a dedicated person, an oblate of sorts, as Seeberger puts it. He has commitments in another world. This makes addiction a special problem. Their behavior may look irrational, illogical to us who aren't addicts, if you're not an addict, but their behavior is actually quite logical and rational and purpose-driven. It's just purpose-driven towards something that's ultimately self-destructive. And this article again is about trying to get inside the mindset, the mentality, the emotions, the things that lead to and prolong addiction. And which leads then to some of the extraordinarily difficult issues of what happens then, going back now to scarcity and rationing. What happens when some of these addicts develop medical conditions, endocarditis in this instance, that are a consequence of their injecting. They have a bacteria that's in the needle that infects them, goes to the valves of their heart, damages their heart, and now their addiction has caused a very serious, very life-threatening, very expensive condition that requires doctors to say, well, look, I can only do so many surgeries. I can't be doing these procedures all the time to people who are going to keep coming back. And this article is like, how do physicians balance the empathy and compassion on the one side with the rationing of resources on the other side? And it's excruciating. And the doctors in this article are like, well, maybe one of the ways you do it is you give the procedure, but you also couple it with addiction treatment, which the doctors have found out is hard because in the United States and other places, especially in the United States, addiction carries a stigma. And people say, hey, we have a limited amount of resources. We have people who are homeless. We have teachers who are underpaid. We have kids who are not getting food. Why don't we take the money and resources to meet that, not the second, third surgery for addicts who are self-injuring? But that's true. And then you read the article and you're like, wow, the people who become addicts are oftentimes, I remember writing, I actually wrote in the article about injecting drugs can ruin a heart. How many second chances should a user get? I was reading it along and I was going, trauma. So many of the people that have become addicts are people who were sexually abused or people who suffered childhood trauma. They're traumatized. So their addiction later on is partly, if not primarily, related to trauma. And if you understand the lifetime path of trauma, addiction makes more sense. And then maybe you can have more empathy and compassion. And I like how the doctors and the nurses in these articles are saying we're trying to balance that. I mean, like, you don't ever want to give up on compassion and empathy. At the same time, we live in a world of scarce resources and we have to ration them rationally. Interestingly, this is data showing that long-term opioid use by county and then percentage Trump vote, it's not a complete one-to-one map. I mean, it's not, but there are overlaps and there's places where these stories are taking place that we read about. and the documentary Heroin and the American Carnage and Injecting Drugs Can Ruin a Heart are often in these areas where there's a lot of trauma. A lot of trauma in these places, not surprisingly, a lot of addiction problems. And deaths of despair. These are the places where the deaths of people are coming younger in life. They're dying earlier than their parents. And these are places where the economy has deteriorated. And these are like Huntington, West Virginia, the opioid capital, along with New Hampshire, and the overdose capital. And hence the film is the documentary set in Huntington, West Virginia, which I've driven through multiple times in my life, going back and forth to St. Louis, my hometown. And I always drive through it and I go, wow, like I'm actually in the place where this is happening. I'm in the place that shows what happens when people don't have a purpose and don't have gainful employment and don't have the social, economic determinants of health. They lack those. Well, a perfect thing that comes in to fill that void are drugs and addiction. And then it profiles people trying in different ways to, whether the drug court judge has got a different role than the EMT responder, who has a slightly different role than the person who's going out kind of doing social work. And they're each of them in their own way are trying to push back on what seems like a futile and fatal problem. But one of the things about being on the ground is you can see people, when you see people who make it, then you're encouraged. Your empathy is recharged. At the same time, they also showed people in Huntington who were like, first responders who were like, how can I keep saving people who don't even seem to want to be saved? I want to go home and take care of my family who wants to live. And every day, it's interesting. In the Heroin documentary, I think it came out and it's mentioned later on. These are firemen, first responders. They're not responding to many fires. And Jan says this, like when she started her career, mostly first responders, EMTs, and firemen were responding to fires and traffic accidents and stuff. Now they're responding to overdoses. And one of you all even mentioned, it was so interesting in your SAC paper. It's so common in Huntington that the woman who overdoses at the Sheetz gas station, people in the store just keep going about their business. It happens so often that even the people there don't stop and like huddle around and try to help and close the door and help her. They just call 911, people come, revive her with the Narcan, the naloxone, and they hope for a better day. Which brings us to the last point, the podcast, NPR, about this amazing, wonderful, life-saving drug, naloxone, which is injected, Narcan, which is ingested through the nose. Wonderful. Like you can't imagine going back to a time when this doesn't exist and people just died. There was really nothing you could do. So awesome, awesome, awesome. Way to go, biomedical innovation sector. It's awesome. This podcast also shows it's also a little bit complicated, and you see it in the documentary, which is, okay, now you're Narcanning people multiple times, like over and over and over again. And at a certain point, just like the heart surgery, is there a limit to how many times that you're going to Narcan someone? Are these, it's about, I forgot what it costs, maybe $50 to $100 a pop for the Narcan and naloxone. Well, I mean, Huntington has other needs too. Like at a certain point, do you not get the second, third, fourth heart surgery? At a certain point, do you not get the ventilator because you're 95 years old and the 20-year-old person next to you with COVID needs it more than you do? At some point, you are faced with rationing, and you hope it's done with empathy, but there are limits. Some of you might know Leslie, who's a student at U of R. She's a fourth year, and she is one of the top EMTs on campus and in the local Richmond area. And she just wrote me this email last year when she took this course, and I encourage you to read it. It's in the PowerPoint. And she said, I've done this. I've been on calls where I've administered nasal Narcan. I've seen it rapidly bring some people back, but I've also seen patients be declared dead in the scene. They couldn't get there in time. I've seen them go from being pale and diaphoretic back to warm, pink, and dry. I've had patients who were so grateful that we saved them, and others who were so angry and combative because we took away their high. I'm telling you, if you're that person and you save someone and they're grateful, it recharges your empathy. If you're there and you're Leslie and you bring someone back and you Narcan them and they strike out at you in anger that you ruin their high, that's going to deplete your empathy. And if you work EMT enough, like the women in like Jan in the documentary, you're going to be seeing the same people over and over and over again. Similar, same people. Overdose, Narcan, repeat. Overdose, Narcan, repeat. And I don't have an answer for it. I don't think Jan Rader has an answer for it. Leslie would not claim she has an answer for it. but it's something you have to be mindful of and something that we have to have a discussion of, because now even more with COVID-19, we have more and more people unemployed. So we may have these issues in greater numbers. Things to think about. I look forward to reading the rest of your papers, and
you have stopped screen share.
I'll see you all tomorrow. Take care.